Hello, everybody. I'd like to welcome everybody to our communication presentation today, Communication in Palliative Care. This ECHO session will be presented by Drs. Jalal Ebrahim and Warren Lewin. So thank you so much for joining us today. I will begin, before we get into our presentation, briefly, I would like to take the opportunity to acknowledge that the land on which I'm presenting from, the city of Gatineau, is the traditional unceded territory of the Algonquin Anishinaabe people. I acknowledge the historical oppression of lands, cultures, and the original peoples in what we now know as Canada. We are grateful to have the opportunity to be present in this territory. Briefly, regarding the Palliative Care ECHO Project. So this is a 5-year national initiative to cultivate communities of practice and establish continuous professional development among healthcare providers across Canada. I urge you to visit our website at echopalliative.com to find out more information and possibly view our previous sessions as well. The Palliative Care ECHO Project is supported by a financial contribution from Health Canada. So therefore, the views expressed herein do not necessarily represent the views of Health Canada. Just quickly, you might, many of you might know Pallium Canada for our LEAP resources, our LEAP courses. Our LEAP core is one of our biggest courses out there. It's an interprofessional course that is accredited with both the College of Family Physicians of Canada and the Royal College. So I urge you to check it out via the pallium.ca website for further information about LEAP. Quickly, a few welcome and reminders. So I'd like to ask you to introduce yourselves in the chat. Please let us know your profession, the region that you're from, and your name, of course. Your microphones are muted. There will be time during the session when you can unmute yourself for questions and discussion. Please bear in mind to put your questions into the Q&A. The Q&A box is different than the chat box. So the chat box, introduce yourselves, make any comments if you wish, but reserve your questions for the Q&A section, and those questions will be addressed possibly towards the end of the presentation. The session is being recorded and will be emailed to registrants within the next week. And please remember not to disclose any personal health information during the session. Brief disclosures. So as some of you may know, Pallium Canada is a non-for-profit. It's funded by Health Canada. The program has received financial support, as I mentioned before, from Health Canada, and we also generate funds to support our operations and research and development from the sale of our Pallium pocketbook and the registration, of course, for our LEAP courses. I myself have nothing to disclose, and the disclosures for Dr. Ebrahim are on the slide that you see here. Dr. Lewin will disclose whatever relationships he wishes on subsequent slides. Once again, the planning committee, they have completed independent control over the development of any of the content that you see that will be covered here today. So I will again introduce myself. My name is Diana Vince. I am the Palliative Care ECHO Project Manager. I've been with Pallium for 6 years. I was predominantly on the LEAP development side of things prior, and I'm really glad to be joining you today. I'll pass it on to Dr. Ebrahim to allow him to introduce himself.
Hey all, very happy to be here. My name is Jalal. I'm one of the palliative care physicians here at Toronto Western Hospital and University Health Network. I did my training in Toronto and have a really special interest in teaching around some advanced specific communication skills when we're having serious illness conversations with patients and families. So very happy and excited to be able to share some of those with you today.
And hi, my name is Warren. I am a palliative care physician in Toronto, also at the Toronto Western Hospital with Jalal. I'm very pleased to be here today. I trained as a family physician and then did an adult palliative medicine fellowship. And I'm just coming on to a decade of practice now. And so all of my gosh, why did that happen moments and frustrations and then learnings. We're hoping to distill and pass along some tools and tips today to you all. So really happy to be here.
Thank you so much. And we also have Aliyah Mamdim, who is part of our support team in the background, along with myself. I will pass it along now to Dr. Lewin for the presentation.
Okay, thanks so much, Diana. And just looking at the chat, it looks like we have a really awesome and diverse group, and we're pleased that you're all hanging out with us for the next hour. So we're going to talk about communication in palliative care. I think first and foremost, we should share that you're all already experts in doing this. What we're trying to do today is name a few of the specific component skills that you're all probably already using, and maybe pass along one skill that is new to you. For any of the teachers in the room, also, some of these are great to tangibly give to a trainee or a learner. And for all of us, when we get stuck or we're really not at our best, it's great to have that toolbox, and we hope to add something or remind you of something that's already in your toolbox. Our specific objectives appreciate that a defined set of communication skills can be used to increase quality of serious illness conversations, as well as to recognize that these skills may increase comfort and confidence to lead advanced care planning conversations. In terms of disclosures, I'll say that I have a relationship with the Department of Family and Community Medicine at the University of Toronto, the University Health Network Foundation, as well as VitalTalk, which is a not-for-profit organization teaching folks how to do this work as best as possible. So I have some funding through these four areas, either to teach or to evaluate and then disseminate knowledge to help us all at a local, regional, national level do this work. And so I will say that I do not endorse one program over the other. We'll talk about some skills from two programs today. And all the skills that we're going to talk about today are generalizable. So wanted to put that out there. What we know is that people are comfortable talking about death, talking about end-of-life care, talking about their values and wishes in Canada. And what we also know is that folks are not talking to healthcare providers about that. We're not asking as much as we probably should as a whole, and they're not coming to us to talk about it. But we can see that people are talking to other people about it. And there's lots of barriers as to why this can happen. And what we want to go through today is some specific skills that may help you in those moments where you say, that didn't go well, or I'm really frustrated, or I really don't want to see this happen again. So the first is a headline. And this is a specific tool that helps us very efficiently share health information. So when I know that I'm going to go and be talking to a patient or a family member, and I have to deliver tough news, or I have to deliver any news, I think about a headline. Headlines are everywhere. We put a picture of the Raptors winning here. We the champs with that picture. It's very clear. It's succinct. We know what's happening there. So in healthcare, most of my patients, I don't know if you can all relate to this, feel lost half the time. They don't really get what's going on. And I think it's oftentimes because the words that we share are not as clearly delivered in the way that we hope they are. And so I find, I know Jalal does too, that a headline can be a helpful way for us to get in our heads and prepare for the information we need to share. So what is a headline? It's information with its associated meaning. And when you give the news, the recommendation is to share that news up front and then offer silence and see what happens next. Usually it's some form of emotion. You can address that and then only fill out that pyramid with additional health-related information if it's needed for a patient, if it's needed for a family, if it's going to help them move forward in whatever decisions or path they need to go on. So a case here is Jamal. He's a 64-year-old gentleman with progressing heart failure. He's had hospitalizations for his heart failure in the past year. He's spending more nights sleeping in a recliner chair to minimize his breathlessness. And he books an appointment to discuss a new medication that he's hoping will better treat his dyspnea. And you've spoken to his cardiologist, and unfortunately, there are no further disease-modifying therapies that are going to reverse his disease. He's not a transplant candidate, and titration of diuretics is his best option to manage symptoms moving forward. And he's already getting up there, so there aren't many options for him in terms of helping him reverse what's happening. And whatever your role is, I see we have nurses, we have physicians, we have care coordinators, we have death doulas. If Jamal says to you, hey, what's going on? I really didn't understand what my doctor told me. I just want to get better. A headline is a way that you can go in and respond. So here, unfortunately, your heart is getting weaker, which is why you're having more difficulty breathing. So the information is that his heart failure is worse. And the meaning is that that's why you're not feeling well. And what I find headlines really help me with is making sure that I attach that meaning. Why does this information matter? How is it actually impacting this patient? I worked in a heart failure clinic here and then in New York City on a transplant heart failure team. And a lot of my patients really couldn't correlate their breathlessness with advancing heart failure. They were so stuck on their sodium intake, weighing themselves, restricting certain foods, titration of certain diuretics, that it got lost that their breathing, their fatigue was actually a marker that their illness was progressing and getting worse. And so the meaning can be so helpful here during your headline. And the trick or the tip is to link a symptom to health-related information. Another example here, as your heart weakens, I'm worried you're likely to be less independent or have episodes where your breathing acutely worsens. And I think it's important for us to plan for these possibilities. So your headline meaning can also be, this is going to continue to occur and we need a plan to help you throughout this time. One thing that people often ask or tell me that they have trouble with, or something that is, they're looking for tips on how to very efficiently and effectively add meaning or talk about kind of an illness trajectory or prognosis. One of the things that we would recommend, and that has helped me personally in my practice, is drawing out prognostic curves. And so we have here 4 common prognostic curves: the person that suddenly dies, someone with cancer, someone with organ failure like heart failure or COPD or liver disease, and then frailty, our dementia folks. I've highlighted our organ failure one here because we're dealing with heart failure in this example. And as you can see, time is on the x-axis. And on the y-axis is function. So how well or how independent or how able someone is going from very high to very low at the bottom. And when I'm giving my headlines, and this work comes out of the Serious Illness Care Program in Ariadne Labs in Boston, what they taught me to do and what I have added to my practice is adding the meaning sometimes in a prognostic lens. And that can be by a way of function. I'm worried that you may get weaker or that your health may worsen over time. That can be the meaning that you're attaching. Maybe you want to talk about prognosis in terms of time. I'm worried that time may be short as a result. And then if you're going to share further, always use a range. I don't know how many people have been there where someone says, but they told me that, he would only live 3 months, and here we are 8 months later. We've lost trust. Now they've lost trust in the system, and we're the recipients of that. So when we talk about prognosis, we always find it helpful to really start broad. I'm worried time is not as long as you probably hoped. Would it be helpful if I gave you a number, a time, a guess? Would that be helpful? Hear what they want. I'm going off on a little tangent here, but that can be your meaning, right? And then if they do want that time, I'm worried time is on the order of months, not years, or days to weeks, not much longer. And your meaning may also be, I'm worried that time is as short as a couple of hours to days. I'm worried that you're dying, or I'm worried that your loved one is dying. And so I think going back, when you're talking about your headline, right? Unfortunately, your heart is getting weaker. That was the information. The meaning could be, and I'm worried that you may get weaker or that your health may worsen over time, right? Let them absorb that. And then you're going to move the conversation forward with that gray line at the bottom. And therefore, I think it's important for us to have a plan to ensure that we have we can provide you with the best care, right? I'm worried your heart is getting weaker. You could add in your meaning there as time, which makes me worry that time may be short. And again, same thing. And I think it's important for us to have a plan to ensure we provide you with the best care. And then only then give more information as needed, and consider using one of these graphs to visualize, because a picture is worth 1,000 words, I think it is, or 1,000,000 words. For the visual learners, for the visual people, I'm a visual person. I find this really works so well. You can even circle the death part and say, many people die from their heart failure. And then you can circle the rest of the graph, the bigger part, and say, I want to be here through all of the ups and downs with you. I'm worried you're getting closer to, the end part. I need to know what matters most to you so we can have a plan to take care of you. So that's all tied in under meaning there, and wanted to just spend some time on that, simply because that's one of the number one things people tell us, help me with, or that we get consulted for in palliative medicine at our site, and wanted to share that. And then, one of the take-home points for today, you've shared your headline, right? You're going in armed now with, here's how I'm going to share information with this person and why it matters. I'm going to give them the meaning. Emotions are processed way faster than facts when people are emotional, when they're stressed, when they're anxious, when they're concerned. And so our job is, after we've shared difficult news or we've shared information, is to expect and then respond to empathically to the emotion that's likely there. Offer silence, and only move forward and give information when you've attended to that. And so we have this kind of barometer here, or meter here. Our goal is not to make people happy. We want to, but when people are facing, life-threatening or serious illness, if the emotions are high, there's angry, frustration, worry, concern, expect the emotion, respond to it, bring people to a neutral state so that they can then engage in a more meaningful conversation. They can trust you more. You'll save time, and you'll probably feel better. And there's data to actually show that you will probably feel better and more engaged with your job. And I'm going to pass it over to Jalal to help make this more practical for this next part.
Thanks, Warren. That was a really excellent description of using a headline statement to pair information with meaning. When I think about this practically, and when I remember facing difficult patient encounters where I hoped to have a serious illness conversation, one thing that I've worried about, and I've heard from others, and I am sure a lot of you folks have faced this in your own practice, is a worry or a fear on our end of, what do we do if we're faced with anger or sadness or grief or any of these very human, very understandable, but also challenging emotions? And so what we hope to do is to give you some purposeful, specific strategies for how to navigate strong emotion from your patients and families in a sort of clear and specific way. Excuse me. So in medicine, whenever we're faced with an unexpected scenario and we feel like we have sort of a backward center of gravity, we're on our back foot, we don't know what to do. What typically works well is having a specific approach. And so you'll see there on the screen in front of you, NURSE statements, NURSE. This is an acronym to describe a specific approach that you can use when you're faced with any sort of strong emotion. So we want to equip you with this so that if you have given a headline statement, you've paired information with meaning, and you're faced with an emotion, you know, I feel on my back foot. I'm not quite sure what to do, but wait, I have some approach or some specific strategies that I can use not only to deal with this emotion, but also to continue to move the conversation and the relationship forward. So I'll go through them one by one, and I'll tell you which ones that I have found the most helpful in my practice so far. So the first one is naming the emotion. For me, this is by far the most valuable. I know, speaking with Warren, he really likes explore, and I'll tell you about that one at the end because he's muted, so I'm going to take advantage. But naming an emotion is a very simple, very powerful tool that shows the person who is emoting at you that you hear them. It provides validation, and it allows them to feel heard and understood in a meaningful way. The way that I practically use this is I always start off with a sort of qualifying statement that acknowledges I'm not in their mind. I don't know their experience, but I care about them as a provider, and I'm seeking to pay attention. So I might say something like, please correct me if I'm wrong, but it seems like this news comes as a really big shock. Or anger is a very difficult one. I might say something like, I hear you. Correct me if I'm wrong, but I'm hearing your tone and I'm seeing your face. I'm wondering if you're feeling upset right now. I probably won't use the word anger. You always want to be gentle, but naming is a good way to validate an emotion and to understand that a lot of times when folks emote at us, the reason that they're emoting is to feel understood. They want you to know that they're sad, or they want you to know that they're angry. And so you can skip over a lot of painful period if you just sort of name it and show them, I hear you. The second one is called understand, U for understand. Practically, I find this one less helpful, honestly. It's sort of a softened version of naming where you're trying to express understanding of a situation without quite presuming you know what's going on. I'll be honest that practically, there's 5 of these. I don't expect you to go away with 5. I don't know if I use this one too often. And so I'll move on to the R, which is respect. This is an opportunity where you can express respect for and acknowledgement for the hard work that a patient or their loved one is doing with regards to their illness. Many times when folks are expressing strong emotion, it's coming from a place of wanting acknowledgement for this effort, this work that they've put in over all these years. They might say to you, gosh, I followed every instruction that the doctor said. I took every medication, and now you're telling me that this is just going to get worse. A great opportunity for a respect statement. The fourth specific strategy, the S, is for support. This is a really important one because after giving a headline statement and providing information and meaning, folks might feel worried or scared about what comes next. A support statement is when you explain you are there to help moving forward. You are there with them on this journey, similar to what Dr. Lewin just expressed using the graphs of function over time. It's a similar statement to, I want to be with you through this whole journey, and here are some specific things that I can do to help. The E, the final strategy, is called explore. This is Warren's favorite. And I definitely agree it's possibly, arguably the safest, the simplest, and the one that requires the least sort of mental exertion on your end if you're feeling a little overwhelmed yourself as a provider. And it's simply asking folks to tell you more. Whatever they said, whatever they emoted, silence, nodding, and asking, tell me more, or tell me a bit more what you mean by that. It's an opportunity to give whoever you're speaking to the stage. It builds rapport. And when faced with strong emotion, it gives you the opportunity to work through it and explore it so that later on, if desired and helpful, you can work through some cognitive aspects as well once the emotion is explored. Next slide, please. So now we have a demonstration with Warren and I. We're going to give you a case. I'll read it out verbally. I will be a clinician and Warren is going to be a patient. I'd like you folks to keep in mind the nurse statements and see if there are any missed opportunities to utilize any of those 5 nurse statements. And if you notice any missed opportunities or things that you would do differently based on your existing expertise or anything you've heard so far, I'd like you to please write it in the chat, and then we'll look through it a little bit right after the quick scenario. So the case is Joshua has advanced pancreatic cancer and was recently discharged from the hospital after being evaluated for a clinical trial, which he didn't qualify to enroll in because he had progression of disease on his recent scans. A home palliative care referral was arranged by Joshua's oncologist, but the oncologist is worried that he has not understood the big picture. You are the clinician, that's me. I am the clinician meeting Joshua for the first time in a virtual video call. Hi, Joshua. My name is Jalal. I'm a palliative care physician asked to see you by the hospital team that took care of you. Is now okay to chat?
Palliative? There must be some mistake.
Didn't your oncologist or your family doctor tell you that I was coming today? I have a referral here.
I mean, not really. They said something about a supportive team or supportive care, but they definitely didn't use the word palliative.
Okay. I mean, it's basically the same thing. Our team can help you with quality of life and to stay comfortable at home as long as possible.
I mean, honestly, there must be some mistake. My goal is not to stay at home for as long as possible. I really want to speak to my oncologist. I can't imagine she would send a referral.
Okay, maybe I can just video call you another day, and in the meantime, I'll speak to your oncologist for more information.
Okay.
So we'll time out there and exit the scenario. And I'm wondering if in the chat, there's anyone who sees some missed opportunities or anything they would have done differently in that scenario. Feel free to just type anything in anytime. From Eve Jonas, thank you so much. No clarification of understanding. That's excellent. I agree. There was no sort of, I think what you're alluding to there is an explore statement. There were so many opportunities to explore what was being said, and I didn't utilize any of them. From ML Barusa, thank you. Omitted not acknowledging the emotion and didn't show empathy. Totally agree. I didn't name anything. I didn't really focus on emotion at all. From Jennifer, opportunity for us to explore why the patient was surprised. Again, you hit the nail on the head, no exploring. Some other pieces, what is palliative care? People mentioning exploring, no empathy, understanding. So this is really great. I love what everyone has sort of mentioned so far in the chat. And Kaya, apologies if I say your name wrong, caution about using the P word. Definitely something that we've faced before. From John Shaw, people equating palliative care with death. So thank you so much for this amazing participation. You folks clearly have done this before and found some really, really great opportunities to do better using a lot of what we just talked about on the last slide. So now Dr. Lewin and I are going to get back into character and time in, and we're going to try to do this differently using some of the strategies that you just suggested to us. Hi, Joshua. My name is Jalal. I'm a palliative care physician asked to see you by the hospital team that took care of you. Is now an okay time to chat?
Sorry, palliative? There must be some mistake.
I imagine, correct me if I'm wrong, but it seems like you're surprised to hear me say these words.
Well, it is. My oncologist said something about a supportive care team, certainly not palliative.
I hear you. And you're absolutely right. My job is to work together with your oncologist, not to replace her, and to support you and your family alongside whatever comes.
I'm still not sure that she meant to make the referral.
I hear you. Can you tell me more about what's going on in your mind right now?
I guess like I'm just trying to make sense of everything. There's a lot that I'm hearing, and it's just really been a lot.
Yeah. I can't even imagine how upsetting it must be with everything that's been going on and everything that your oncologist has told you.
Yeah, I obviously wish things were better. Yeah, I thought things would be better.
I wonder if it would be okay if I asked you a few more questions about what could be better. And we'll
Okay.
time out. So this was a great exercise to basically have Dr. Lewin and I put into practice what all of you folks suggested. And so in the interest of time, because you are ahead of the game, I won't ask you what I did because I basically just did what you told me. I tried to use supporting statements, understanding statements, naming statements. And what I want to highlight is that at the end of the scenario, even though we can argue we addressed empathy, Joshua, the patient, wasn't happy. He wasn't pleased. He's still facing a massive illness. And it's difficult to not want to please everyone that we work with, but realistically speaking, that's not a goal that we should put onto our own shoulders. We're looking to respond and care with empathy, and this was a great example of that, and kept the door open for conversation and support as opposed to closed in the first case. Next slide, please.
Can I add one thing, Jalal?
Yes.
The one thing I do want to add, and I see a lot of it in the chat, so it's great, but I want to make sure that the point was made that most questions that come about, or when there is emotion, we may hear them as questions, and they probably have an emotional and a cognitive aspect to it. So by me saying, no palliative, there must be a mistake, Jalal could answer, oh, I have the referral very cognitively. Let me explain what palliative care does. Or he could do what he did in the second scenario, which is, I can't remember now, but explore it. And that's where the nurse statements come in. It's when that emotion keeps coming to you, where you explore or you use those nurse statements to say, maybe there's an emotional side to what this person is doing. Maybe that's what's behind this emotion or their question, and try to go to a nurse statement to build that rapport, build that trust, and then you can go back in and do all the cognitive work and explaining things. I just wanted to make sure that people could hear that's when they work so well.
Absolutely. Thank you, Warren. And just to respond to Jocelyn's question in the chat, no clear statement of the purpose of the referral to palliative care. Functionally, I totally agree. Whenever I'm introducing myself to someone, I always confirm upfront if they were expecting to hear from our team and what their understanding is of what palliative care is. And I would start with that in the beginning. So this is sort of a very isolated scenario, but functionally, I totally agree. And I love that the questions are coming and that this is becoming interactive. So I'm going to spend time answering some of these questions because I want to help you folks in what comes up in real life. So from Eileen, how do you deal with the anger when there is a delay in diagnosis, missed by the medical team, or delayed for reasons like the pandemic? Okay, yeah. Well, we can definitely get back to it. We'll put it in the Q&A and move forward. Thanks, Warren. Let's move on. Next slide. Warren, do you have control of the slides? You don't. Do I have Oh, perfect. Thank you. So a specific skill that we can use in addition is using I wish statements instead of I'm sorry statements. And next slide, I'll explain a bit more what I mean by this. Often when we're delivering news that might be challenging, we hope to say something along the lines of, I'm sorry, but many providers feel a bit strange, worried that this might be suggesting something was done wrong or suboptimally. And really what we're trying to do is to articulate empathy and to build rapport. So one specific strategy that we can work in when seeing strong emotion is using I wish statements. So instead of I'm sorry, one opportunity or a skill to try using is I wish things were different, or I wish that I had different news to share today. Others like using I had hoped for. I practically use I wish, and I find it works very well, especially in combination with some other specific strategies that I'll share on these coming slides. Next slide, please. So one combo skill that you can use is a wish worry statement. And this specifically you can use if you're faced with expectations from family or patients that you feel are misaligned with yours or discordant, or potentially not realistic based on the clinical context. So one example is, I wish that I had treatments to make your heart stronger. However, given how advanced your heart disease is, I worry that our focus is shifting now to how we can help you feel best, rather than having ways that we can change or fix what's happening to your heart. So it's a way of shifting the conversation and basically expressing to folks, we're in a different place, or I'm worried that we're in a different place. Specifically, if folks are not open or feeling a little closed off to having a conversation around something like advanced care planning, there will be situations where you feel you can do this iteratively over time and you can just wait until the next visit to give them time to think. Conversely, there will be times where you're worried that this is a conversation you really feel should be had now because of the clinical context, and you worry that delaying it might open them up to harm or to value discordant care. So in that situation, folks ask, what can I say to try to help them to have this conversation or be open? And one specific strategy you can use is, I wish we didn't have to have this conversation. I'm worried that if we don't talk about it, at least a little right now, we might not have a plan to stay in control of your care if you were to get sicker. Yes, we will move forward. So next slide. Thanks for the timing. The final skill is I wonder statements, and that's a specific way to move a conversation forward after a wish worry statement. Next slide. So I think it's a way to open a door into sort of hypothetical worlds to make it more psychologically safe for folks to talk about whatever serious illness topic you want to talk about. I wonder if we can talk about what it might look like when your quality of life is worse than what you would call acceptable. That's one sort of simple example, and you can combine it with wish worry statements to functionally move forward from, I wish things were different. I worry that if we don't have this conversation today, we might miss an opportunity. And I wonder if we might talk about what we might do for you if you were to get really sick. That's one simple example. And next slide, please. We had a little demo, but I think in the interest of time, we can move on. We really wanted to focus on nurse more. And I'm going to hand it back to Warren to talk a bit about this guide for advanced care planning discussions.
Thanks, Jalal. So I think this is our last slide, our second to last slide. For those of you that do or lead goals of care conversations or advanced care planning conversations, or pick up the pieces after someone has done a conversation and maybe it didn't go as well as the patient or family would have hoped, please note that if you aren't already using a conversation guide, they exist. There are evidence-based guides out there, and we just wanted to put forward that that is something that you have access to through various programs, and they are patient-tested language for those. So those of you that are worried maybe that talking about this or some of the language that you'll share is maybe upsetting for people. This is patient-tested language, and our patients who helped with this said that this is okay for them to hear. It's adaptable, so you don't have to use the words on the page, but just know that the approach is starting from the top, working towards the bottom so that you can make a recommendation and help your patient or family. And here are, is a summary slide of what we had hoped to accomplish, and over the remaining time with the Q&A, and some sample resources that continue to talk about this or to summarize some of what we've talked about today. advancedcareplanning.ca has some great stuff. Ariadne Labs Serious Illness Care Program, if you want to learn how to use a guide. VitalTalk for the specific nurse and wish skills, and the conversationlab.org is something that we are starting at our institution from a systems-based lens that has some great tools as well that we've adapted and can be a reminder for the stuff that we talked about today. So thanks so much, and I think we can do questions now. So Eve Jonas had a question. Can you briefly go back to I wonder slide? We can. Was there a specific question? You can pop it into the Q&A. And while we're waiting for Eve, Sarah, is there a link for the Serious Illness Conversation Guide that was shown as an example? There certainly is. I am going to just put one into the chat. We've adapted ours here, and I can share this one, and otherwise it's through Ariadne Labs website. Great question. Great, Eve. Let us know if you got it. So Andrea White, thanks for the questions. I notice a lot of similarities in your approach and that of motivational communication. Yes, good pickup. So my understanding is that the tools that we've talked about today come from, I think it's 10 or 15 years of usage and data and evaluation. And they built the program and got these tools from the K-12 literature on education principles, as well as the motivational interviewing and other types of psychology research, where we are trying to help empathically support people and move to behavior change. So yes, it's very similar, totally. Jalal, I don't want to hog, but if you're okay, I'll just keep reading.
I'm learning too. Please continue.
I love the wish, worry, wonder statement, so applicable to many settings. I will definitely incorporate into my seniors' mental health and addictions practice. Thank you. Thank you for the comment, Carrie. Wish, worry, wonder changed my practice. All of these tools did. I gave a similar talk to our emergency medicine doctors during COVID. They needed tools in the moment. And just saying wish, I wish things were different. People are demanding, that their loved ones come into the hospital when they couldn't, right? I wish things were different. I wish they could be here, just wishing with them, right? And wonder also really moves the conversation forward. And for people who never want to have the conversation or they're too worried, like Jalal said, to make a very psychologically safe place, put it in the future, right? It's just a hypothesis. So much easier to think about a potential as opposed to their reality, which is not what they want. So I'm wondering if we could talk about maybe some of the what ifs, right? It's psychologically safe because it puts it into the future. The other thing it does is it gives control back to this person, right, to this family member who's losing so much autonomy, right? By you just asking them permission, I wonder if we could talk about this, right? You're getting their consent, which gives so much control back to them and helps to alleviate some of the distress. And Aileen's question, and I'm just going to go back because I copied it in my own area here. How do you deal with anger when there is a delay in diagnosis, something missed by the medical team, or delayed for reasons like the pandemic, and now the disease is more advanced? Totally. I know what I would answer, but Jalal, I know that you would answer that amazingly well also. So curious to know what you'd say.
Yeah, absolutely. I think the first thing that I would do is to try to ask myself, what's the emotion that I'm hearing? And it sounds like the emotion is anger. And then I would honestly go through the nurse statements and say, how might I address this and empathize? I think in reality, functionally, I would say something along the lines of, I can't even imagine how difficult it must have been to go through that. Can you tell me a bit more about how that went? And please tell me how that went. And if they are sort of expressing that, but they're looking for next steps, if I feel like I've addressed the emotion, but they're shifting now after addressing the emotion more to a cognitive place where they're saying, what can I functionally do about this? This doesn't sit well with me. Truthfully, I refer these types of folks to, patient relations. And I say there are organizations that exist within I work in a hospital setting, but in whatever your setting is, after you've sort of addressed the emotion, if you feel like you've built rapport and they're still looking for answers, this is an imperfect system we work in, and patients and families have rights around expressing this sort of thing, opportunities for improvement, and sort of looking into how things were handled. So I'm very open with that. But after I try acknowledging the emotion, so consciously going through it in my mind, what is the emotion that I think is going through, and seeing if I can try a couple of nurse statements, usually involving the explore statement. Because I think in the past, what these people have likely faced is deflection and avoidance and fear of sort of repercussions or litigation from whoever they're talking to. And I wonder, truly, I'm not using a wonder statement on you, but I truly wonder, has someone they affiliate with the healthcare system ever just let them talk about it and vent it out? So I try to give them that opportunity, and I use a strategy Warren taught me, which is if you feel like there's anger coming at you and it's not really at you, it's at something else or bigger, I try to lean on a wall or something beside me, and I let it go past me because it's not actually about me. So that's what I would do. But Warren, very curious what you'd do.
I don't know if I have much more to add. I think exactly what you said. I stay curious and I lean into the emotion. I actually physically, so that I'm glad Jalal we recruited because he was such a stellar resident and fellow clinician. In addition to that physical piece where I move and lean as a reminder that I'm in control as well, and this isn't about me, I'm going to let it pass by. I think about leaning. So many people run away from strong emotions. It's scary. We weren't taught how to do it. It's uncomfortable. I think about leaning into emotion. And as I see emotion, I think, how can I lean into it? And then I break down like any other skill. When I learned how to read a chest X-ray, when I learned how to perform, a ACLS protocol for Code Blue, there are structured ways of how we approach that. And I think about emotion, that's my trigger. So I'm going to lean into it. And then I can have a nurse statement or a W statement like wish or worry to help me out there. So that's what I'll add there. There was a question or a comment. I also include their spiritual beliefs, God's will, into the conversation if this is important for their meaning and understanding. Thanks, Sarb. Totally. I also want to share that these specific skills that we talked about today were simply how to efficiently and concisely share information. And then once we know a patient heard what we said, they're probably going to be emotional. How do you then support them and lean into it? And we gave some skills. So these are just component skills that fit into a much broader conversation that you're going to be having. And certainly, those values and beliefs and understanding are all part of kind of the big picture conversation. Absolutely. And with spiritual beliefs too, at least in my world, this is something that my trainees and some staff clinicians from many professions come and ask us, how do we deal with the miracle question? How do we deal with, what do we say to help lean into people's spiritual beliefs? And it's the same thing, right? Explore. It's why I like it so much. Tell me about your spirituality. Tell me about how that's helping you navigate this. You can use a respect statement. I know that your spirituality beliefs are so important and are helping you get through this. I really admire that. Tell me more about it, right? Understand as well. It helps me understand where your strength comes when you talk about your spirituality. Can you tell me a little bit more about it? Right? That's kind of how the nurse statements can work. And I find it's one thing to present them, and in a big 1 hour lecture, this is how we do it. It's another thing to actually get into the moment and see where that cognitive versus emotional piece is. And I think there is a question about that, if I remember. Yeah, Kate, I wonder if you could speak to responding to emotions when it comes across as a cognitive questions. How could this happen? I have seen medical professionals start to cognitively explain when really the person is just in shock. Totally. I think we've all been there, Kate, and that is so hard to see. One thing I do is I step in, after the clinician is really going at cognitive and totally missing that that's not what the patient's needing in that moment because there's so much emotion. I'll say, would it be okay if I jumped in for a moment, get permission from them, and then I'll just go and say, tell me what's going through your mind. I see that this might be difficult, right? So explore and naming, they go hand in hand, and see where that conversation takes you to. There's emotion, you've got to lean into it and address it. And sometimes, in my experience, the clinician leading the conversation may actually go back and say, wait a second, they asked about the creatinine. I need to talk about that. Or they wanted to know about the scans. I want to talk about that. And I'll say, I think it's so, so important. Would it be okay if we just spent a moment asking a few questions about how so-and-so is taking this in? This is a lot. And then bring it back to not asking them about the patient or family, about anything clinical, but do exactly what Jalal did in the example. Tell me what's going through your mind, right? Let the person get that emotion out because they have it and they need to express that. And that's the skill on how to do it. That explore statement. Tell me what's going through your mind. I hope that answered your question. I don't know, Jalal, if you have additional thoughts.
I think you did a great job. I mean, in general, and I was just typing an answer to a different question, so I was a little bit preoccupied, but this is around the cognitive, how do you address cognitive questions?
Yes.
Yeah.
But when
if I'm unsure,
is when you're bearing witness to that happening.
Yeah. I think, if I'm unsure, if I'm bearing witness, I always try to go after the emotion first, and I try to let them push me on honestly into a cognitive discussion, and that way I know I've addressed it and they're ready.
Yeah. Which question were you typing or fielding?
I was typing a response to Zorika's question because I thought it was really unique and challenging, and in the interest of time, I thought I wanted to try to get to it.
Got it. Okay. Anything to add for it, or do you want to keep doing it for just typing?
Well, I'll just say, Zorika, for your question around people who have language barriers, I would say it's really tough. I would try to ask about their goals, their values, their priorities. In whatever language they use, if I think it's realistic, I would try to say something like, I am your teammate. When you say you want, I want also. If it's realistic, then it's easy and just use very, very simple language. If it's unrealistic or you think you're in a different place, in an ideal world, I would try to use translation, because I think that it really, what we say, these tiny words really have a massive difference. And without knowing sort of what their language level is, it might be challenging and really easy to sort of misspeak. So I'd say if they have sort of realistic goals, it's easier. If it's you're feeling like you're in a different place than where they feel you are, I would really, really try to get some translation in there to do the best service possible for this person. I know that's kind of I don't mean to dodge the question, but you just ask a great question. It's hard.
And I know we're maybe short for time, but one thing I will share is there's a paper that just came out. I'm trying to see the date, 2022, so late last year, where they took these tools to Japan, different culture, and taught some people and asked questions. And what they found was that this translated at least to Japan. And I think there's a lot of work that needs to be done to see culturally how these tools might work or not, and how they need to be adapted for various folks and different cultures. But just to know that there's a lot of work being done, and language and culture, it's a huge field that needs study and is being studied, so that we know how to best help all the patients we serve.
Fantastic. I'd like to take this opportunity to thank everybody for having joined us today for this wonderful presentation. I know that we can spend hours and hours on end on this topic. It's definitely an important topic. Please fill out the feedback survey. A link has been added in the chat. You may consult the chat box, and a recording of the session will be emailed to registrants within the next week. Once again, thank you so much to our presenters. Thank you for everybody who participated and joined us today. We look forward and we push you to go check out our website. We have so many sessions coming up. Thank you so much.